He's an infectious disease physician and assistant professor at the Yale School of Medicine with an interest in HIV and STIs. He's also a clinical consultant for the HIV, STIs, and MPox for the Connecticut Department of Public Health. And Dr. Achhra is going to be providing us with some updates on MPox this morning. So Dr. Achhra, please take it away.
Hi, thank you, Linda, for the introduction, and I'll just share my screen in a second. Give me 1 second. Okay. There we go. Okay, hopefully you guys can see and hear me now.
Yes, we can. Thanks.
All right, great. Well, thank you. Good morning. And I'll, just give you some brief updates on the monkeypox or MPox epidemic that we saw, and we still not over yet. And I know some of you have perhaps more experience with monkeypox, and some of you are not. So I'll keep this more sort of a refresher / update. So there'll be hopefully something for everyone here. Do not have any conflict of interest to declare. And here is the outline of my talk. I will touch upon the something on epidemiology and prevention and clinical spectrum and the management. And as I said, I'll just focus more on what's new in this area if there is anything. I also want to upfront acknowledge my colleagues here at DPH. Some of you are here, Dr. Sosa, as well as Dr. Paranandi and others who helped me put up these slides together. So I think the first and most important update, if you saw on my slide, it's MPox, and it's not because I am trying to write a short form. It's because the name has changed. Hopefully all of you have noticed this. And that was in response to the concerns of monkeypox being sometimes stigmatizing or discriminatory. And so WHO and then followed by CDC late in November have all come to the consensus that this would be referred to as MPox henceforth in all the reference to the disease. So where are we now in US and in Connecticut? In this last year, 2022, we saw about 30,000 cases in the United States. There were 23 deaths with globally about 85,000 cases. And this was updated as of last week. I think there is a weekly update from CDC, so some new numbers might come in. But generally, seems like the new cases have come down substantially in the United States, and as well as globally in the West, at least where the epidemic was ongoing. So we reached a peak in around July, August period, and then there is a sustained decrease in the number of new cases reported, but down to about 1 to 2 cases or less a day in the country. As you also probably have heard, a majority of these cases were in gay, bisexual, or other men who have sex with men. And I also want to here mention that testing rates have also substantially declined. So not seeing in this graph here, but we're not testing nearly as much. I think way below the testing capacity. So that is something to keep in mind when we interpret this decline in number. How are we doing in Connecticut? Well, again, similar to the national trend, I think the numbers reached their peak in around August and then have come down. So from the end of November here, there were 0 cases. There were cumulative of 144 cases reported so far. Men made 140. of these cases. And as I was about to say, well, let's celebrate nearly 2 months of 0 cases. Dr. Sosa shared with me the other day that we already have our first case detected in 2023. Not sure when this person actually acquired, but bottom line is that it is not completely over yet. And so, these numbers will get updated, but, hopefully we will continue to see the trend of low cases, but we have to be continue to be vigilant here. So I hope some people may know this, but some may not. So I wanted to put this out there. Approximately what % of all MPox that were diagnosed in the United States were also the people living with HIV? How many of those, were co-infected? What %? If you don't know, take a guess. It's 5, 10, 20, or 40. I'll give a second if someone wants to chip in the chat box here. 5%, okay, that's a guess. Good guess. Anyone else? All right, 10. So Robin Clark, 40, 10. So it seems like many of you are leaning towards 5, 10, and actually one of you did get the right answer. And in fact, it was much higher than you would expect. It was 40%. So that you could imagine the subgroup of the population that was being selected by the MPox. And this was seen in multiple surveys. So, and some surveys actually found up to 50%. So, so this is a good estimate to remember. Very high prevalence of HIV co-infection. Also, over 40% of these people reported at least one STI in the preceding year. And what this implies to us is that we have to also think about HIV testing, STI testing, and also remember it's an amazing opportunity for HIV prep. So for example, somebody is presenting themselves for a vaccination request and they are HIV negative. And it's probably an opportunity to discuss PrEP. We in our clinic, for example, this has not been published yet, but when we reviewed the cases who presented for the vaccination request, we found that a big chunk of them could be on PrEP, but they were not on yet. So it presented that opportunity to also discuss PrEP. And this, I think I already mentioned that, in the blue bars here are the total blue and light and dark blue, the total number of tests being done. And as you can see that the test number of testing being done is also substantially down. So something we should keep in mind when we interpret the positivity data. Okay, so I will move on to the prevention part of it. We discussed the post-exposure and pre-exposure prophylaxis for MPox. So as you all are probably aware, so we have 2 vaccines available, but the one that we are using as a preference is a Jynneos vaccine. Jynneos is a vaccine which is a live but attenuated virus, as opposed to the other one called ACAMP, which is a live replication competent virus, so much more reactogenic. We haven't used that because we haven't needed to, and Jynneos is much safer and much better option, and we have those in stock. So luckily, we haven't had a need to use the ACAM. So Jynneos is licensed as a series of 2 doses administered 28 days apart. Their suggestion is that you at least should have a 24-day delay from the first dose, and you can effectively give up to 35 days or even longer. So the standard dose was a subcutaneous. It was a 0.5 ml, and that was also approved for people under the age of 18. However, later in the year, we also discovered that intradermal dose, which is much lower, so just 0.1 ml. So therefore, more people could get the same amount of stock of vaccine, was approved only for adults, and there's no change in there. So we still, for adults, use the intradermal, but for people under 18, you still have to use the subcutaneous. One question I often get is there antibody testing, which would tell us if they had immunity or immune response, like we do for Hep B, for example? And the answer is, so as far as I know, we don't have any tests commercially available which can answer this question. So initially, when the vaccines came, we didn't really know how effective they are. We know that those were approved, for in smallpox and then for MPox, but not in the clinical setting. So there was no clinical trial done yet, and so we didn't know what exactly is the real world efficacy of vaccines. So we have some more insight on this now. So this was the MMWR CDC publication late last year. And what you see here is the top line is the dotted line of the people who had no vaccination. And then the dark blue lines are the people who had either 1 or 2 doses of the vaccine in the prior 14 days or sooner. And then bottom line is that, reassuringly, it was pretty good effect size here, a pretty solid efficacy of the vaccine. The relative risk of acquiring an infection in unvaccinated versus 1 dose only was 7.4. In other words, even the 1 dose was seeming to be effective. And then 2 doses was even more effective. And one would expect that 2 doses would give you a longer lasting immunity. So we'll see that. And then the number that's been put out so far is around 69% as an efficacy number. There are some confidence intervals around it. In people who are immunocompetent, this number is thought to be around 75. But again, this might be more than that, because some people who are getting the vaccine after getting the infection within that short period, so it's hard to say. But so far the data looks reassuring in terms of the efficacy, and makes us feel confident about recommending it. So I just want to also point out about the who to give this vaccine to. So one way to do it, one option is the expanded post-exposure prophylaxis, and this, or you would also hear this as being referred to as PEP++, and really the difference there between PEP and PEP++, which I see causes some confusion sometimes, is really how lenient you are in offering the vaccination. So if someone has had a known exposure, then you would refer this to as PEP. But if someone who was in a setting where they may or may not have had a known exposure, but in a high risk setting, then you do call this a PEP++. In simple words, we have enough vaccine now that we can offer it to people who might be at risk of acquiring. So the top priority here are people who are known contacts to someone with MPox. However, people who, for example, are not known to have an individual contact, but say they were in a setting, for example, in a commercial sex venue or in a group sex party or something like that, where they didn't know an individual if they came in contact with, but there was a case identified in the whole group, and then that person would still be eligible to get the post-exposure prophylaxis. And this is thought to be most effective if given within 4 days of exposure. However, you can give up to 14 days, but maybe having a reduced efficacy. And then in an immunocompromised person, especially who is at a higher risk of progression, you may consider giving it even after. However, it is discouraged. You shouldn't give a vaccine if somebody who is already having symptoms of MPox. In that case, we will see in the management part, but in that case, the vaccine is probably futile, but it's probably too late. And then the pre-exposure is a one where also I think the general sense here was that people, especially in men who have sex with men, we were fairly lenient in our setting, and people who were requesting it, we would essentially give it. But the people here who are probably most fruitful in terms of targeting our messaging and getting the vaccine to are the people who are MSM, especially those who have more than one sex partner or have a recent STI diagnosis. And then the occupational exposure was another thing. So a lot of providers who are working with them or in the laboratory also sought the vaccine. But in general here is that if someone who has risk for STIs, then they also probably should be discussed monkeypox, MPox vaccination. I think this is always a good reminder that like majority of our interventions, people who need the most often get left out. And so there is a CDC's MPox vaccine equity toolkit, which gives you some ideas and suggestions on how to engage the populations who may not, maybe underserved, for example. So far, the data seems that we have done pretty okay in vaccinating, ethnic minorities, for example, Hispanics and African Americans. But I think that's an ongoing effort, should be a conscious effort from all of us. So another update here is the vaccine safety. When it came, again, there was some concern about how safe it is, although we had some data, but we didn't have a large scale clinical data at the time. So again, late last year, the surveillance of the CDC's safety measures. So as you know, CDC has two ways to monitor the vaccine safety. One is VARIS, where it's a passive reporting, who anyone can report, any clinician, even a patient themselves actually can report. And the other one is active VDS, where they have a select network of hospitals and clinics who have the specific methodology to go through their medical records and stuff and get and report a specific adverse effect. So that's more active. So the general gist here is that it was quite safe. Did have a fair bit of reactogenicity on the injection site. So a lot of them reported injection site erythema and swelling and pain. It was much lesser with intradermal than subcutaneous, but still a fair bit. Some of them reported some sort of a papule or a scar, which lasted in several weeks even. The other most common symptom was pain and myalgia, and some of about 10% or so also had pyrexia. And so, but generally the most common one was the injection site reaction. And then what about the more serious ones? So we know that ACAM, the one that's replication competent vaccine, has an association with myocarditis, pericarditis, and other more serious effects. But luckily, Genius, so far the signal does not suggest. There were, I think, 2 cases of myocarditis in the denominator of several thousands. And so the understanding in the paper was that this was similar or lower to the background rate of myocarditis we see in general. And so the conclusion here was that the current data do not suggest an increased risk of myocarditis after receipt of Genius, but the possibility of a small risk cannot be excluded. So we'll see, but it doesn't seem to be as reactogenic as the predecessor of ACAM. So generally speaking, good news. Okay, so clinical spectrum, I'll kind of refresh your mind and share with you what we have seen so far, and also some new observations that have come in. So this is a historical, I think the slide that was made mid last year and hasn't really changed. What we are seeing is this characteristic rash, which is preceded by prodromal symptoms. However, what we have seen are so many atypical cases where there was a rash, was characteristic, but it was localized, not generalized. So localized in the areas of genital or perianal areas, or areas of body which were involved in the sexual activity, so around the mouth and so on. Rash sometimes was not disseminating to other parts. It was being recognized in outpatient clinics, and it can be easily confused with STIs, and I'll show you some pictures. Prodromal symptoms may not be occurring, may be very mild. A recent meta-analysis put a number of around 8 to 10%, where people may have mild or no symptoms at all. So that's debatable. Most people have some symptoms, but there may be some asymptomatic, but it's still a little controversial, but some people think it's around 8 to 10%, but not sure. And again, people can be infectious once symptoms begin, until the lesions scab and scab falls off. So that can take up to 3 weeks. So just to kind of remind you to not to forget the MPox testing and how deceptive and similar it can look to some of the other well-known infections that we deal with. So on the left is the secondary syphilis rash, on the right is an MPox, and again some difference there, but just clinically alone you may not fully appreciate. Again, I'm sorry about the old terminology of monkeypox there, but that was because the slides were made at the time, so it's supposed to be MPox. And then again, showing you here is molluscum contagiosum, for example. And then we'll have another case discussion. Hopefully, I'll show you some herpes, which can also look very similar to HSV. This was a spectrum of rashes we saw. It could be very subtle, as you can see, and it could be very prominent as well. So again, being watchful is the key here, and not to forget that just because the rates are coming down that we should stop testing altogether. That's quite the opposite. Moving forward. So this slide is basically I put in here to remind people that even though most cases were doing fine, this infection can be pretty devastating for someone who is immunocompromised. And as I already showed you, about 40% of the people who are HIV positive. So you could easily see a small subgroup of these people who are HIV, as well as with low CD4 counts and not on treatment. So actually just a couple of days ago in Lancet ID, 2 cases were published from Bellevue Hospital in New York. And these 2 people were not on treatment, but HIV positive, not on treatment, and had CD4 counts actually below 50. And so I want to give you a bit of a warning here, is that the image is quite graphic. And that is because both of these individuals had a pretty devastating facial infection, leading to facial gangrene, and then both of them actually died. Both of them also got the antiviral TPOXX, but clearly did not help them. So it's a humble reminder that even though most people have recovered, this can be a pretty nasty infection. Okay, as I said, this individual as well as the other individual with the same story both died. So keeping in mind immunocompromised population is important. Perhaps vaccination is even more important in those individuals. Okay, briefly on the treatment part, have we learned anything new recently? Again, the reminder that most people really seek care because of the pain. And monkeypox or MPox here can cause severe pain and complications involving vulnerable anatomic sites of the cases that required hospitalization. Most of them actually required the hospitalization for pain management. And this was because the lesions tend to be in the sensitive areas around anorectal area, for example, or pharyngeal mucosa or penis or vagina. And those can be areas which are very sensitive. And so the pain could be out of proportion to the appearance. And there were also reports of secondary bacterial infections. We certainly saw a couple of cases at our hospital, and those did not help pains. A lot of this was supportive care for most people. And so the confusion and question arises around how and when to do the antiviral. So the one that's available is tecovirimat or TPOXX. And I want to remind people that this was FDA approved for smallpox. It was never approved for MPox. And that's part of, so what the way that we got around that was that the CDC has this investigational new drug IND, so that you don't have to seek specific IRB from your institution when you're prescribing this. And this essentially is an umbrella coverage so that clinicians and facilities do not need to request their own INDs. Under this protocol, it is allowed to be used, but it requires informed consent from the patient. So it's essentially a study drug, not so much an FDA approved drug is a way to see it. And the indications, and people ask, why are the indications so limited and why not give it to everyone, right? And especially if we have more stock in now. And so I'll tell you why. And the reason is that we don't actually know how much it works. So for now, the most important indications where we should offer in a hope that it helps are the people with very severe disease. Some of the examples I showed you, and in fact, those two individuals probably did not benefit from TPOXX. But so we want to use it where we think it may help or probably likely to help. And these are the people who have, so for example, hemorrhagic disease or large confluent lesions, or we saw a couple of examples where it was near the eye, so affecting the ocular, threatening the eye or vision. Certainly would require a TPOXX, and hopefully it helps in those cases. Also, the concern comes is when they are having, for example, in the areas which can stricture and require long-term care from long-term complications. So those cases where we could also consider TPOXX. The other one would be the people who are having immunocompromising conditions, which may progress to severity. And that's where probably you would have a lower threshold to prescribe. And also very young people, perhaps, and then people who have other skin conditions, such as atopic dermatitis or eczema, where the complications could be much worse. The documentation, just want to refresh, so there's no major change here. But it can be prescribed relatively more easily now, and certainly in Connecticut, we have not had major difficulty. There are these 3 forms which you are expected to do, but I think the key to know is that you don't have to wait for these forms to be finished before you can prescribe. So you have 7 days period where you can catch up. So if your patient needs it, you can still go ahead and do it. But the CDC requires you to do this intake form. There's a FDA 1572 form. And then the informed consent is the most important one on top there. And then the adverse event is another form which you may need to do if it happens. But the key here is the consent, and then the other 2 here. These can be emailed to CDC, and the pharmacy can also help you figure this out. But the key is here that you can still prescribe without having to wait for this form completion. In Connecticut here, as I said, the documentation is required, and what we are doing is that the Connecticut University of Connecticut Health Pharmacy Services have this in stock. And so if you are suspecting it, you can fax them or call them, and then they can deliver the tecovirimat within a day. And there's a fax number here. I haven't covered here the inpatient side. Hopefully the inpatient pharmacy can help you, as some hospital systems are stocking it as well. So you may not need to do this to the Connecticut pharmacy. So it depends where you work. But the outpatient side, it has worked pretty well for people who prescribed it. So the reason I think we are restricting again is A, we don't know exactly how effective it is and what stage of disease it is, where most effective. So ACTG from NIH have an ongoing trial called STOMP. Well, so far the issue is that they're not seeing enough patients to enroll in a trial, but if you do come across a patient and wants to refer, we certainly have a site here at Yale. And hopefully this trial would answer the efficacy data on tecovirimat. So far, we have not discovered any safety signal here. So the most common issues that we have learned were headaches and nausea. The main concern here was that it's a lot of pills. So 3 pills BID for 14 days to the total of 84 pills. And that's probably the number 1 challenge we saw in outpatient prescription, having to take as many. There is an IV formulation available, probably be given in the hospital setting. It has a fair bit of infusion site reactions. The more important also concern here is that the drug seems to have a low barrier of resistance. We haven't discovered any clinical resistance yet, as far as I know. But in the in vitro data, we know that it can be overcome by the MPox virus. And so therefore, we are also trying to have some sort of stewardship in prescribing this, and not just tolling it out to everyone, concern being that we may lose this option in the future. So I think of my time or have passed. So I'll just summarize here that cases are down, but they are not over. So do not forget testing, especially if you are testing for ulcerative disease or rash as a part of your STI workup. And then don't forget the HIV, including HIV PrEP, and then other STI treatment. Jynneos vaccine seems to be effective. We can say that with more confidence now. It's quite safe so far, as we know, and it's more available now. So I think the vaccination option is still open for people who need it, and you have to then recognize who might be the best person to benefit from PrEP and expanded PEP. And the blanket sentence here is MSM with more than one sex partner or recent STIs are probably a top priority, and then anyone else who may be at risk. Wide clinical spectrum of rash in clinical presentation. So as I like someone of my mentors used to say, try to test yourself out of it and don't talk yourself out of it. So if you come across and if you have a doubt, just test it. Don't try to talk yourself out of it. TPOX is available for those who have a severe presentation or a risk of progression. It requires the informed consent because a part of a study, efficacy is unclear, but use wisely for the potential of resistance. So I will stop here, and I see some chat here, so I'll take questions. Thank you.
Thank you, Amit. We do have maybe 1 minute for questions. So there was a question from Bernie. Would it be beneficial to promote vaccination as part of standard of care for all MSM as a strategy for prevention?
Yeah, Bernie, great question. And the bottom line is that we have been fairly lenient for the same concern. And I have a lot of connections in Australia where I've worked before. And for example, in New South Wales, that's what they are doing. Basically, they're saying all MSM, if you're sexually active, just get the vaccine. So it won't be wrong. I don't see a downside there, but I guess the availability was a concern initially. It seems like that's not a concern so far.
Yeah, and I'll just say that we are, we expect, like I said, MPox is not gone away, and I don't think that it's going to go away. And we actually expect it'll increase as the weather gets nicer and people, have their summer plans and things like that. So we're actually going to be working on kind of a reminder campaign for everybody about MPox and a focus on vaccine. Vaccinations have been continuing. They have never stopped. And we are focused on more vulnerable populations, including homeless persons, sex workers, and folks like that. So making sure that we're getting a vaccine to the people that need it, but also being sensitive to the fact that we saw the progression of MPox from, a more affluent population to more vulnerable and susceptible populations. Definitely saw that in our race ethnicity data and things like that. And so I think we're really sensitive to that and understanding that not everybody might identify as MSM. And so making sure that we're making sure that, we're getting the message out to everybody that needs it. And so this is going to be a big effort this spring. We just got some additional funds to be able to do this, to kind of make that big push so that hopefully we can limit whatever outbreak happens this summer. Commissioner, I'm sure you have something to add there.
Thank you. I mean, obviously, I agree with everything Dr. Sosa just said, but I just want to reiterate a couple things on that point. I mean, I think we've been thinking very closely about the fact that spring is coming. There are going to be Pride events again that will come up. I would strongly suggest that the criteria for vaccination be along the lines of what you're thinking. I mean, I think if you have somebody who's having multiple sexual partners, regardless of orientation, whatever orientation they are, or whatever their identification is, multiple sexual partners consistently been identified as a risk factor here. And we need to stay ahead of this. That's the only way we're going to keep where we are in Connecticut. So I would strongly encourage and advise everybody to do that. And this group has been working hard on our MPox vaccine vans that have been going out there into all kinds of different areas. We have over 100 vaccinations that are happening every single week right now. So we have not stopped, and we need to keep doing that to be able to make sure we stay ahead of this.
Thank you, Commissioner. I
Okay,
think this is
thank you. It's good.
a great presentation, great discussion. And again, if you do have any questions that come to you afterwards, please shoot me an email and I'll be sure to make sure I get it to the right person so that we can get answers to everyone. We are running a little bit behind, but I think we still have time for a quick 5-minute break. And so if everyone can just come back